Okay, I think we can start. Just I want to introduce you, dear Professor Jeff. You hear me?
Yes.
Okay. In the beginning, I'm so happy, and we are all lucky to join dear Professor Dr. Jeffrey Strakowski. He is one of the eminent figure in the topic we are talking about, the all nerves all over the body, each electrodiagnostic or ultrasonography. So he is a clinical associate professor, physical medicine and rehab department, Ohio University. He's also a director of MSK Research, McConnell Spine and Sport and Joint Center, Columbus. The topic in our episodes today, it will be electrodiagnosis and ultrasound for brachial plexus, which this is my choice. So I want to know if there is any values to adding the ultrasound for the brachial plexus, any informations we can get, or be in each besides with the electrodiagnosis or not. This is where we will see with this amazing tour and journey. Enjoy all. Take your coffee or tea, and the screen with you, dear Professor Jeffrey. Yeah.
Great. And thank you very much. It's an honor to be here.
Thank you.
And hopefully I can make this work. There we go. Okay, like you mentioned, we're going to talk about electrodiagnosis and ultrasonography of the brachial plexus. I'm going to talk about some also the nerves around the shoulder in the same region. I actually have been promoted to clinical professor, so no longer associate. Couple of disclosures I've done a couple of books. One, ultrasound evaluation of focal neuropathies. It covers a lot of this material. I actually have a second edition coming out very soon. So learning objectives for this talk, we're going to contrast echogenic appearance of and common pathologic conditions around the brachial plexus and talk about the value of ultrasound in conjunction with electrophysiology. I use this picture because things are not always as they initially perceive, and sometimes we can identify things that you may not expect. Now, we're limited in this talk by 30 minutes, so we're not going to talk in a lot of complicated cases, but I'm going to try to get across some of the concepts that we use for ultrasound. Okay, first I like to point out when we have a problem, a neurologic disorder, we're going to do electrodiagnosis, and all of these are extensions of our history and physical, as we all know. But what's our goal when we're going to do electrophysiology? So, and that's true for any peripheral nerve lesion or focal lesion. We want to localize the lesion to the extent possible. We want to assess the relative severity, i.e. axonal injury versus neuropraxia, right? And this is the single biggest reason to do electrophysiology, because this can tell us something that really nothing else can. Okay, distinguishing those two things. We also want to rule out concomitant disease and more generalized conditions too. That's particularly important when we're dealing with something complex as a brachial plexus. What's the goal of ultrasound? Well, the first thing's relatively the same. We want to localize the lesion to the extent possible. But one big difference is we can sometimes identify the anatomic source of the neuropathy, which electrophysiology doesn't generally do for us. Okay, so if there's the single biggest reason to add ultrasound with electrophysiology, it's that. Okay, and we can also rule out concomitant problems. It can be comorbid musculoskeletal issues, other things that maybe we didn't expect, or maybe contribute to the symptom complex. And so that adds some value too, where electrophysiology does not do that necessarily. Okay, it's always important to distinguish cervical radiculopathy from brachial plexopathy. And I just point out, you know, we know this anatomy, but really paying attention to where is the deficit neurologically or electrophysiologically, or even clinically. So are we dealing with a group of nerve symptoms, or are we dealing with dermatomes? And remember that most cervical radiculopathy pain doesn't fall in the pattern of a dermatome, it falls in the pattern of a sclerotome. And this is comes from Charles April, and this distinguishes some of those issues. And the brachial plexus is even distinct from that. So we have to realize that these won't all look the same, and those clinical things help us a little bit distinguishing these. So when we look at brachial plexopathies, they can be traumatic, they can be non-traumatic, and everything from compression, such as even post-radiation and malignant infiltration. That's a really important distinction sometimes if we're dealing with somebody with a tumor and trying to decide is a worsening related to a malignant infiltration or post-radiation. And that's something ultrasound can help us with. We'll talk a little bit about. Also, thoracic outlet syndrome. Sometimes people have clinical pain with no measurable neurologic deficit, and we can look at the anatomy sometimes, and that'll give us some clues. Okay, neurologic amyotrophy can also get complicated sometimes, and looking at both physiology and anatomy will help us for those complicated conditions. Okay, and I'm not going to do too much about the anatomy other than we want to look at everything in terms of the root level, trunk level, division level, cord level, and terminal branch level. Okay, the one area where ultrasound's slightly weak is the division level because it's obscured by the first rib and the clavicle, but there's some tricks you can use to actually scan above and below that and see most of this region, okay? But being aware of this complex anatomy is very critical when we want to come up with the right localization. Okay, and again, mentioning the same issue, there's a distinction between dermatome sensory loss and peripheral nerve sensory loss. For example, the ulnar nerve tends to end, the sensation ends there, but I know at least in where I am in the United States, I can't tell you the number of people that have trouble distinguishing a C8 radiculopathy from, an ulnar neuropathy sometimes, or a combined ulnar and median neuropathy. And some of these sensory clues, can really help us. And that's only true usually if there's true sensory loss. Sometimes the patient is not very adept at telling us just where the tingling is, and sometimes that's not very localizing. But when you talk about true sensory deficit, there's certainly a difference. Okay, so when we get into electrophysiology, and I know from this committee you guys are familiar with this, but needle EMG for brachial plexopathy is probably the single most important in terms of localization. Okay, because we have a complex set of different muscles that are innervated, and knowing our anatomy and distinguishing where the abnormality is and where it's not is the most critical. But we can also use our distal sensory nerve action potentials and compound muscle action potentials for prognosis, and that's often helpful. F waves are helpful in some situations, most especially if it's a medial cord, lower trunk, C8 pattern, using the F waves for our conventional muscles that we record from, including the APB and the ADM, are helpful. We can also do spinal nerve stimulation to bypass some of those problems that we may have with more distal entrapments. Okay, so needle EMG in general is best for localization, and you want to make sure you adequately sample enough, including the paraspinals, to try to distinguish the different conditions. Okay, and this can give us also assessment of relative chronicity. And that helps us sometimes distinguishing the nature of it. So are there large duration motor unit action potentials, or and also how many fibrillations we see, things of that nature. And you guys are well versed in that. I'm not going to go into too much detail. I mentioned trying to distinguish sometimes an infiltrative brachial plexus in somebody, for example, that has breast cancer or lymphoma or other types of cancers. Myochymic discharges can be seen in 50% of people that have post-radiation plexopathy. And sometimes that's a clue. The absence of myochymic discharges doesn't tell us there's no radiation plexopathy, but it certainly can clue us in when there's worsening. Okay, and here's an example of myochymic. I thought I'd show that.
10. This is a display of grouped discharges. If they're not under voluntary control, these are myochymic discharges, 2 to 3 hertz. Note that the amplitude is greater than 200 microvolts, so that they're motor unit potentials rather than single muscle fibers.
You don't see those very often, so I thought I'd show those. Did anybody want to see that again, or is that good? We good? Okay, we'll continue
10.
On. Okay, distal sensory nerve action potentials. Okay, so those are critical also. And as a general screen for brachial plexus, even we generally do this at Ohio State for most people that come in with numbness or weakness, is I like to look at digit 1, digit 3, and digit 5 for looking for anything that might be up in the plexus. And that gives us this distal sensory nerve action potentials for what really accounts for the superior trunk, middle trunk, and inferior trunk. Okay, and so it looks for more distal entrapment neuropathies. So if we're trying to distinguish a post-ganglionic neuropathy, meaning a brachial plexus problem, from a pre-ganglionic neuropathy, meaning cervical radiculopathy, and if there's sufficient axonal injury, these will be lower. And it's nice to compare both. We like to compare the median and radial sensories here. You can tell the radial sensory has no motor component to it. Looking at the amplitudes of the median nerve on both sides of the wrist, looking also for carpal tunnel syndrome, but also what's the height and amplitude of that. And same thing with this, correlates with roughly C8, and also screens for ulnar problems too. Okay. And so it's nice to compare those. When we're looking at amplitudes, though, we have to also be vigilant about noticing the relative width of the digits. For example, if somebody has a very large thumb that's very wide, you can expect that the amplitudes are going to be a little smaller than a thin long finger. So we have to take that into account also. Okay, and then we also can use the medial and lateral cutaneous nerves of the forearm. These are helpful at times, also doing the same thing, looking to try to distinguish a pre or post ganglionic problem. Okay, so the medial cutaneous nerve of the forearm also is an extension of the musculocutaneous nerve and has mostly C5 and C6 fibers in it. I think I said that backwards. I'm sorry. That's the lateral that I just referred to, the lateral cutaneous nerve of the forearm. And the medial cutaneous nerve of the forearm has the C8 and T1 fibers in it. Okay. And these are nice in situations where you may have distal entrapment neuropathies like ulnar neuropathy, carpal tunnel, and we aren't able to use these sensory nerve action potentials. Okay. So, and using distal compound muscle action potentials from our conventional muscles are also helpful. Again, if we have secondary entrapments, using the pronator quadratus with this technique is helpful. Also, for looking for C8, we can record from the triceps for C7, biceps brachii or infraspinatus for C5 and 6. Okay, we can also do spinal nerve stimulation. Okay, and we can stimulate across the lesion in that capacity, and doing side-to-side comparisons is helpful. So we can do those at C8, C7, C6, and record from the selective muscle, and that's also very effective. When you do this, you have to be aware that what you're doing is stimulating a single root as opposed to an entire nerve, so you're only going to record from the muscle fibers from that specific nerve. In other words, the compound muscle action potential amplitude when you stimulate C8 from the abductor digiti minimi is going to be roughly 60% or so, compared to what you would record if you just stimulated the nerve directly. So that's also very helpful. So when you get into imaging now, we want to, again, look at the anatomy. We want to try to identify, is there enlargement of peripheral nerves or changes in the echitecture at any of these levels, and help us identify, is there something structurally affecting the brachial plexus, and is there a focal enlargement or abnormality? Okay, and so we can look at the root levels, we can look at the trunk levels, we can see the divisions to some extent, cord levels very well, and also the branch level of the brachial plexus, and we can identify those all separately. So that's very helpful with ultrasound. So I'm going to get into imaging different parts of the brachial plexus now. Okay, and one thing when you're just learning this for the first time is using bony landmarks or things that you can see. So for example, the transverse processes are all unique, and they have their specific patterns that help us identify which root that we're looking at. Okay, and so here's a position for scanning the supraclavicular portion of the brachial plexus. We always want to be in a relaxed position and have the patient in a relaxed position, but we can use the tubercles of the transverse processes to identify the root level and which specific root level that we have. So it also correlates with where we are in the neck. So we always want to pay attention to where we have our transducer positioned. But every transverse process and short axis, the transverse process and short axis have these tubercles. And what's unique, for example, about C6 is it's a very wide tubercle. It has a very prominent anterior tubercle. So this is the anterior side. And it has a good posterior tubercle. This is also called Chesniak's tubercle that we use in pain management sometimes to identify that. You can feel that on yourself. It's a very prominent anterior tubercle. And we can see that the nerve root comes out in short axis between that tubercle and the post tubercle. And we'll see a few of those. We can also turn the transducer 90 degrees, and we can see the nerve roots in longitudinal view. So this is as though the patient is on their head. This is the C5 nerve root, and we can identify that in between the scalene muscles here. So we can see if there's a brachial plexus or a root avulsion. We can identify if there's fluid around or a pseudomeningeal seal, and we can also see abnormalities within the context of that root. This is C7. Okay, C7, you notice, is wider and bigger than C6 under normal circumstances. Again, we can see that. We can see it branch out rapidly here, okay, between the scalene muscles. Okay, this is again is another thing looking at surrounding anatomy that we can also use to help identify. That's the internal jugular vein, the carotid artery, that's the longus coli, sternocleidomastoid, and this is again our anterior tubercle of C6 and our posterior tubercle of C6, and we know then that this is the C6 nerve root, okay? And here is the interscaling portion. And we take this back, we see the division of the C6. And now this is the same thing in short axis. We see the division of the C6 fascicles here, and this is C5. And so we have the anterior scaling, middle scaling, and C7, C6, C5. So we always want to correlate both of these in both axes, okay? And then we can see the vascular structures as well. Okay, again, this is the anterior and posterior tubercle of C5. Now C5, you'll notice, is actually got a much smaller tubercle than the anterior tubercle of C6. So it's much more narrow and it's superior. And so, we can easily identify C6 first, and then we can move cranially and caudally and find C5 and C7. Okay, so here's an example. This is C6 coming out of the anterior tubercle that's wide here, and then you can see the, actually this is the anterior tubercle. This is C6, and this is C5 root that sits right on top of it. And we scan back and forth with our transducer to see it. It'll come off as we scan caudally. It comes off like a sunrise. Okay, and then there's C7. A C7, you'll notice, is unique, and that's another place we can identify this. It has a posterior tubercle, but it has no anterior tubercle. Okay, so that's what's unique about C7. Remember, C6 has a very wide tubercle and big anterior tubercle. There's no anterior tubercle with C7, but often a big posterior tubercle. This is important when we're looking for neurogenic thoracic outlet entrapment as well. This is where a cervical rib will attach in that case. And it's also where you can have a prominent posterior tubercle that can cause compression at the outlet level. Okay, and so this is becoming the trunk. As this comes off, it becomes the trunk level very quickly. C8 comes from deeper and will join and make the inferior trunk with T1, which is way lower. This will proceed on to make the middle trunk, and the superior trunk is C5 and 6 as that coalesces together. This is C7 in long axis. Okay, you notice it's not as quite as wide as C6, but it's also a very prominent nerve root between the anterior scalings and long axis. Again, this is a C5, it's much more narrow, so we can just take another view of this carotid artery. Sternocleidomastoid overlies these. This is actually the phrenic nerve right here. Okay, C7 has that posterior tubercle, but no anterior tubercle. So that's what's unique, okay? And the C8 root actually has no tubercle, anterior or posterior, so it comes off a bony shelf. So this is C8 here. And that's just, notice the position of the transducer in that case. Okay, and again, here's the brachial plexus, C5, C6, C7, and C8 coming together. Again, so we see the vascular structure, sternocleidomastoid, anterior scaling, trunk level, the brachial plexus, middle scaling. And another picture of the same, anterior middle scaling. And just so you can see a few of these, you can identify these really well. Here's C7 and C8, or T1 and C8 coming together here. And this is already, the middle trunk and the superior trunk have already formed. And this is more caudal, and this we started getting towards the clavicle here. Okay. Now, one thing that's different, if some of you are experienced with ultrasound, you'll say, well, people ask me, well, why doesn't this look like the median nerve or look, polyfascicular? Okay, so there's an example of the median nerve. This is a high frequency scan of the median nerve. You can really see an individual fascicle. This is an early bifurcation or a bifid median nerve. And that's because the nerve fibers at this level, at the root level, haven't yet differentiated. And so they become more differentiated once they make it to the branch level, the brachial plexus. So they will look monofascicular for two reasons. One, they're less differentiated than the nerves are at this level. And the other thing is any nerve that is encased by bone isn't going to have the same amount of reflection as a nerve that is encased around by muscle. So we can see the detail a little more readily here, but they look a little bit more monofascicular at the root level naturally. Okay. And so here's an example of, so this is a high school football player who got a stinger, and this is an example of using these roots. The C6 root is extraordinarily big. It actually overwhelms the entire transverse process. And so we're able to look at these nerve roots with injury and actually see anatomically the stretch. And this is helpful for football players, for example, because they may not have a lot of neurologic deficit, or they may early on, but they want an answer well before we'll get all the information we need from electrophysiology. So this is one more reason, an example of where ultrasound helps us, because we see structural changes in nerves before we'll see all of the anatomic or all the changes electrophysiologically. So we don't have to wait for Wallerian degeneration to determine there's an abnormality. And this one is significantly enlarged, and we can do side-to-side comparisons to assess it. Okay. So again, that's the transverse process. That's the peripheral nerve, or the C6 root. This is side-to-side comparison from the good side, which is much smaller, to the side that's enlarged and been stretched. Okay. And we can do the same with C5. There's an enlargement of C5 and C6 compared to C5 on the other side. And looking at them also in longitudinal is helpful. Okay. And same thing in interscaling, we can look for other abnormalities. So we're going to talk about the cord level of brachial plexus now. And he was caught looking at the concert without his phone. So it's a little unusual these days. Okay, so cord level of brachial plexus, we've gone below the first rib and the clavicle. And this is where we can see retropectoral thoracic outlet entrapment. This is the pectoralis minor in long axis. Coracoid process is here where its origin, and pectoralis major is on top. This is the axillary artery. So we can identify the cord level of the brachial plexus. They're basically labeled based on their relationship to the axillary artery. Okay, so we know that this is the lateral cord because it's lateral to the axillary artery. This is the medial cord, and this is the posterior cord. And so we can look for sizes and changes and abnormalities there. Okay, and that will sit between the axillary artery and the axillary vein, which is here. Okay, more of the same. Pectoralis minor. You can see the nice bony acoustic landmark of the coracoid process, which is misspelled, should be an A. That's the lateral cord, medial cord, and posterior cord. Okay, and this is a relatively normal position, and we can see this is the pectoralis major. We can actually also see the medial pectoral nerve in its vessel in between the pectoralis major and the pectoralis minor, so we can identify those relatively easily. Again, just more pictures of the same: lateral cord, posterior cord, medial cord. Now this is an example of suspected retropectoral thoracic outlet, and what we see in that circumstance is the pectoralis minor is very tight, and so when they do any abduction or flexion of the shoulder, we'll start seeing bowing of the pectoralis minor on the neurovascular structures. So in this case, this is the asymptomatic side in the same individual, where it's basically concave or flat anteriorly, and we see this convex pattern here when they're tight, and that can be from a number of things. Patients with Ehlers-Danlos, patients with myopathies, pectus excavatum, or other pectus abnormalities, we see this routinely where they get changes. And so what they basically do here is they compress the medial cord very frequently, and they'll immediately get, with this provocative maneuver, sensory changes or numbness affecting the C8 distribution or medial cord aspect of the hand, or the ulnar aspect of the hand. So we can actually see dynamically some compression on the cord. Here's another example. Okay. And one that's a little more subtle. Okay, so I'll talk about the branch level of the brachial plexus here. And that's down here. We can see the musculocutaneous nerve, axillary nerve, median nerve, the two medial and lateral roots of the median nerve, radial nerve, and ulnar nerve. Okay, so here's an example of that. Now I call this the clock, and it's a good way to remember this. If we have the transducer basically in the axilla at this point, and we can scan, and if we have the left of the screen anteriorly, then we have what I call a clock here. So in the clock, the median nerve usually sits about 10 o'clock, and this is the lateral cord actually, or portions of that. And ulnar nerve sits roughly at 1 to 2 o'clock. Radial nerve usually sits about 4 o'clock in that clock. So here again is the same thing. Okay. Reason I have this labeled lateral cord instead of musculocutaneous nerve, you'll see it's very large. This is an anatomic variant. And most people will see the musculocutaneous nerve coming between the coracobrachialis, okay, at that level. But in this case, it's very large. And this is an anatomic variant where all we're seeing is the medial root of the median nerve and the lateral root of the median nerve with the muscocutaneous nerve. And as we keep scanning, we'll see the lateral root will come back and join the median nerve here. But the radial nerve is here roughly at 4 to 5 o'clock. Ulnar nerve is here. The medial cutaneous nerve of the arm and forearm sit roughly at straight up 12 o'clock. Okay. Again, this is anterior. This is posterior. More of the same. Ulnar, radial, median, and two components of that. There's the muscocutaneous nerve. Okay. And these are supposed to be videos, but they're not activating. So more of the same. And as we keep scanning, you'll notice they kind of move apart. Muscocutaneous nerve moves down. And we can see these branches between the muscocutaneous and median nerve also. And so this helps identify any compression or injury way up at that level. Okay. And then we're going to talk about axillary nerve here. So there's axillary artery. So this is looking at the branch level in longitudinal view, and we can see those nerve fascicles also in longitudinal when we're looking for injuries. Okay, and there's the axillary artery, and we can use Doppler imaging to illuminate it. Okay, and then one more concept is looking at muscle ecotexture is very critical for brachial plexus. This is a case of neuralgic amyotrophy that affected the median nerve, where we compare the pronator quadratus side to side. Okay. Okay, and I'll talk briefly. I think you wanted me to go about a half an hour or so. I'll just whip through some of these quickly, but just to show some other things we can look at. Spinal accessory nerve, phrenic nerve, suprascapular, long thoracic, axillary, muscocutaneous. I'll go through these quickly, and then we can take questions. So we can identify the spinal accessory nerve too. This is helpful in trauma. That's the sternocleidomastoid. Okay, and when we're looking at some of these nerves that don't have a lot of area where we can see really well or distinguish really well, we can always remember to look at muscle ecotexture and look for denervation. So we would look at the sternocleidomastoid, and we look at the trapezius if it looks denervated. So we know if the sternocleidomastoid is denervated, then we can recognize that the injury is up higher. If it's in the posterior triangle of the neck, which they often are from biopsies and things like that, then it's just going to be the trapezius that's denervated. And we're looking for changes within the nerve itself. Clinically, sometimes it can be fairly subtle. We know we get lateral scapular winging with trapezius weakness, and we do that with abduction. Okay, we can do certainly nerve conduction studies and compare those side to side. And we have to identify if it's a high one, we may be below the level of the lesion. We may be above the level of the lesion if it's a lower or posterior triangle one. Okay, and there's an example of the spinal accessory. We can see that around the sternocleidomastoid. The greater auricular nerve sits up and also in that region as well. And we can identify that this is actually the spinal accessory nerve in longitudinal view. So we can see that following the underbelly of the sternocleidomastoid and omohyoid, which is below it. Okay. And again, I said I'd go fast just to show you some things we can do, and then we'll talk about questions. This is ultra high frequency. This is 48 megahertz, and we can really see some of the fascicles of the spinal accessory nerve. Okay, this is seeing more detail. This is the branch of the spinal accessory nerve to the sternocleidomastoid. So this is really high frequency, and it's allowing me to see extreme detail. There's the vagus nerve. Okay, and there's the main trunk of the spinal accessory nerve that will traverse the descending trapezius. This whole thing is the carotid artery. Okay, and this is the spinal accessory as it moves towards the trapezius, and we'll go there to innervate different portions of the trapezius. And so we can look for areas of enlargement or injury. So that helps us, electrophysiologically, we may not have precise localization. We can distinguish it whether it's denervating the sternocleidomastoid or different parts of the trapezius, but it's very difficult to localize greater detail. This will allow us to localize a focal injury with enlargement within portions of a millimeter. So it gives us much better localization for a nerve injury of this nature. So there's the trapezius, levator, scapula, and we can see the spinal accessory nerve between those two muscles. The other thing we would be able to do in this situation, if it was denervated, we could see ecotexture change in the trapezius and compare it to the neighboring levator scapula. There's an example of a denervated trapezius, spinal or sternocleidomastoid, okay, compared to a healthy one on the other side. So this one is completely denervated. Okay, and sometimes in the United States anyway, we have issues with higher body mass index than you probably do in Egypt. So sometimes it's a little harder to see some of these, but we can look really carefully. You can see the trapezius has some atrophy here, and it's a little harder to see the lateral winging, but you can identify it if you look carefully. Okay, now this patient was sent to me with concerns for a pectoralis or pectoralis major problem. They thought he had denervation to the pectoral nerves, and that's really not what happened at all. What he has is a spinal accessory neuropathy, and he has forward protrusion of the shoulder, so it gives this appearance. But that's completely normal, and we could we could look at this muscle and see that it's normal on ultrasound, as well as look at it with EMG. Okay, here's a trapezius again, a normal one compared to a denervated one. Okay, so always looking at side-to-side muscle architecture is helpful. Okay, this one's partially denervated compared to the normal healthy sternocleidomastoid. Okay, and again, this is an example of an enlargement. So this is somebody that had sternocleidomastoid atrophy, and their trapezius really didn't look very bad, and we're trying to figure out, how does that happen? Okay, so electrophysiologically we couldn't distinguish that, and it turns out that the injury was at the branch to the sternocleidomastoid right at that level, whereas the branch of the trapezius was not overly injured. And so that gave us a sort of a paradoxical appearance of denervation, and that allowed us to sort that out. Okay. And there's little tiny nerves that we really have no electrophysiological ability to assess, including the supraclavicular nerve. This can be injured in somebody that has a surgery, for example, for a clavicular fracture. We can identify these on ultrasound and look for enlargement here. So this is the supraclavicular nerve that we can see, and we can see the different branches from the superior cervical plexus, and that comes out over the middle scalene muscle. Okay, so nerves that aren't readily obtained or assessed with electrophysiologic techniques, sometimes we can identify abnormalities. Okay, phrenic nerve, really quickly, we know that comes from C4 and C5 predominantly, and little C3. We can identify that very well. Okay, that again is something electrophysiologically where we can determine its relative function, but we can't always localize it. And so a case where the nerve is injured somewhere within the supraclavicular brachial plexus, we can actually look and see if there is an abnormality by identifying the phrenic nerve. Here's the electrophysiology, and this is the way we do the diaphragm compound muscle action potential. Okay, but here we can identify the phrenic nerve very well as it sits in this top of the anterior scalene and then moves towards the chest wall as we scan inside. So another example of the phrenic on top of the anterior scalene. So it sits between the anterior scalene and the sternocleidomastoid. So any sign of focal enlargement would tell us precise nerve injury. And oftentimes this is a manifestation of neuralgic amyotrophy or Parsonage-Turner syndrome. And in that situation, we can distinguish, it's hard to also distinguish electrophysiologically, but we can look at it with ultrasound. And in that situation, the entire nerve will generally be enlarged rather than a focal enlargement. So if we see an entire nerve enlargement, we figure it's probably an autoimmune condition. And so that gives us some insight into that. Again, this is the C5 contribution to the phrenic nerve. So we can see the branch from the C5 root. This is C6, this is C7. There's the phrenic moving on top of the anterior scalene. And dorsal scapular nerve can also be seen. And I'm going to move along to finish up here. We can also see the nerve to the subclavius for the phrenic nerve. Now this is a long axis view, and I mentioned muscle ecotexture. Sometimes trying to distinguish, do we really have a proximal C8 problem, or is it something further down? And I've had some challenging cases along that, but we can look at the muscle ecotexture of the pectoralis minor. This is the axillary artery and long axis. Here's the clavicle. So if we move our transducer over, we either towards us or away from us, we can see the lateral cord or the medial cord of the brachial plexus on the other side of this axillary artery. Okay, this is the subclavius muscle, and this is a nice muscle sometimes to look at architecture-wise because this is a C5-6 muscle, and this is a C8-T1 muscle. And so we can look at the contrast. If we have different portions of the brachial plexus that are affected, we can use that muscle architecture, most especially when we have a really confusing anatomy, say there's radiation damage, other kinds of structural injuries. We can look at that muscle architecture, and that can help us a lot. And that's a more challenging set of muscles to do with needle EMG, but you can do it. Long thoracic, medial scapular winging. Okay, we can see the long thoracic nerve here as well. And we can also, most importantly, look at the muscle architecture of the serratus anterior. I know if you're experienced electrophysiologist, there's a lot of frustration sometimes getting needling the serratus anterior in this condition because it's usually atrophied and actually hard to find, but we can see it in very good detail with ultrasound. Okay, and we can see the long thoracic nerve here as it departs the trunk level of the brachial plexus as it moves between the middle scalene and then out to the chest wall. So we can look for injuries up in that area as well. And as I mentioned, if it's a neuralgic AMI atrophy or it's an autoimmune, then it will be enlarged throughout its entire course rather than a focal injury. Okay, and another picture of that. And we can look at the serratus anterior compared to the latissimus dorsi, and that's the nerve sitting right there. Okay, another one. And I think I'm going to finish up here. Suprascapular nerve quickly, look at muscle architecture. I guess this is a good one to look at too. So looking for any enlargement in the nerve, looking for posterior labral cysts is important, okay? And we can identify those also with ultrasound and also look at muscle architecture as well, okay? There's our nerve conduction for the infraspinatus and getting a compound muscle action potential. And here's looking at the suprascapular nerve coming off the superior trunk. There's a suprascapular nerve right after C5 and 6 coalesce together. We can see the suprascapular nerve come out and then it'll move across the scalene to the posterior shoulder. And that's the suprascapular nerve with the suprascapular notch. And there it is again at the suprascapular notch. Sometimes we'll do radiofrequency ablation procedures for people with tractable shoulder pain, but we can see that in great detail with ultrasound. And this is a nice way to identify a posterior labral cyst. So that's a posterior labral cyst. This is the humeral head, posterior labrum that's got some irregularity, and the infraspinatus muscle here, which is a little denervated, and cyst again. And then we can see the suprascapular nerve really well because of the increased through transmission of this cyst. So this is something that we can act on quickly, even with ultrasound guidance. We could drain the cyst while we're waiting to decide what we're going to do with the posterior labrum. And that can take pressure off the nerve. Okay, so that's one additional advantage of ultrasound. Besides electrophysiology, we not only can identify the basis of the problem, sometimes it allows us to even act on the problem and help treat it. Okay. And axillary nerve, boy, I'm going long. So would you like me to stop here? Okay, axillary nerve. And we can see that very well under the humeral head. That's our scanning position. That's axillary nerve under the deltoid. So we can look for abnormalities, and that's a long axis view of the axillary nerve. Here we see the axillary nerve coming off of the lateral cord of the brachial plexus. This is the medial cord, lateral cord, and here's the axillary nerve going over the around the humeral head. So this is a common place of injury, mostly, especially from a posterior shoulder dislocation, and we can identify a stretch and see if it's in continuity. And here we see it in the quadrilateral space as well. So we can identify cysts in that area, other signs of trauma. Here's muscle architecture from a denervated deltoid compared to a more normal deltoid. And we can use the musculocutaneous nerve. We already showed this nerve conduction technique for the distal sensory part. We can do musculocutaneous by recording this for the muscle. And it's a nice bright signal that sits between the coracobrachialis and brachialis. That's the nerve and lung axis. This can be traumatized in a stretch injury. And so we can not only identify that it's abnormal, we can localize it relatively well. As we can follow the lateral cutaneous nerve of the forearm and medial cutaneous nerve of the forearm. We can also see that much easier too. Electrophysiologically, it will be usually absent if it's injured, but we can localize it very well precisely with ultrasound. Okay, more pictures of that. And thoracodorsal nerve is just, I thought I'd show that as well. Okay, so again, I mentioned neurogenic thoracic outlet. We look, a lot of people that we see, it's from a retropectoral side. And again, I showed this picture already, but we can, here's an image where we can put some stress on it and see if there's any stretch. This one looks pretty normal. Here, this one's slightly abnormal. We have a thickened pectoralis minor, and you see a little bit of bowing, a little compression on the medial cord, and this immediately induces symptoms in the patient. One's a little more dramatic, and this one's a little more extreme. Okay, so this one is causing a great deal of so this allows us to see a situation where there's nerve symptoms related to dynamic influence, but there's no persistent neurologic deficit. We can look at the architecture of the muscle, that's all normal. And this is why this is such a frustrating condition, because we may not see any static abnormalities with static imaging, and we may not see any electrophysiologic abnormalities, but we do see dynamic changes. And so that's a helpful thing for us. Again, we can see this dynamically and see the stress it puts on the cord level. Okay, and I think that's unilateral abnormal versus the normal side. So the point of this discussion overall is not to say we need to replace EMG by any means, because they both have extreme value. We want to certainly maintain the physiologic value of electrophysiology, and we add the anatomic value of ultrasound. And so these really are two things that work very well together, and there's no reason to think one versus the other. They both add acumen to our assessment. So they're a happy marriage. And summary, these are just some things we always want to optimize the image and always have a comprehensive differential diagnosis. And if you're just learning ultrasound, I always tell people what seems impossible today will one day be your warm-up. So thank you very much. And this is beautiful Columbus, Ohio, when I go out paddleboarding.
Yeah. You have a lot of fixed days. Yeah. Okay. Thank you for this amazing talk and presentation as usual, dear Professor Jeff. Okay, I think I will start a little of my questions that I want to ask. Anyone need to ask Professor Jeff, please put your questions in Q&A box, please. First, I believe in nowadays, it's very important to add the electrodiagnosis as well, the ultrasound in adjacent to each other. In some cases, I think today I say a case which has a crush the lower end of the forearm. Then he did with an orthopedic surgeon an upper reduction internal fixation. Then one of the plastic surgeons do grafting at this area, which affected almost ulnar site. And this patient, after 1 month, has a paraplegia at the ulnar distributions. So he requested me to do electrodiagnosis, which I found no abnormalities at the ulnar nerve motor, at this distal or at the elbow side. And then I did an inching or short segment protocol, and I found a little bit conduction block at the pisiform area, which the patient's clinical signs and its quack examinations that not matching with the patient case. Okay. Without any clue. So the ultrasound to give the answer. there is an enlargement of the dorsal cutaneous branch at this area with some fibrous tissue around the flexor digitorum profundus, little bit 7 centimeter above the styloid. So this is the main issue. This is the home message that we can get from your topic today. The ultrasound can solve or get the any queries that electrodiagnosis cannot reply it. Yeah.
Yes.
Okay. First question, in lung thoracic nerve, which is electrodiagnostically, especially when do any needed EMG for the diaphragm, it is, sorry, lung thoracic for the serratus anterior. It's challenging and dangerous a lot. So can we replace the ultrasound? Can get more informations than electrodiagnosis?
I think so. That's a great question. And I think that I get more information by doing ultrasound than I do from electrophysiology. So think about it this way though. When somebody comes with medial scapular winging and they have a thoracic, or they have a long thoracic injury, or you believe so, you know, there's usually some other dysfunction in the shoulder as well. There's, you know, certainly pain when they move. And so the role, I think, of electrophysiology in that case is to make sure that we're not missing a broader injury. And so I would still probably do electrophysiology to establish everything else looks healthy around it, and there's not subtle abnormalities elsewhere in the brachial plexus. Because to be honest, that's an unusual injury. Okay, the long thoracic will see it. Most of the time it's neuralgic amyotrophy. And with that condition, oftentimes you will find other abnormalities. Most particularly, you want to identify, are they part of that 5 to 10% that has maybe some genetic tendency, and you may see some other changes. So I will still probably use electrophysiology to establish that there's no other problem. And you just mentioned the frustration of doing long thoracic with needle EMG, because, you know, there's not really a very good nerve conduction technique. There's some that have been described, but most of the time they get volume conducted responses that don't help you. And then when you have an atrophied lung, you know, serratus anterior, you're trying to feel around, and are you getting the rib, or you getting, and you can't tell. And I mean, I've had that same trouble. You know, you can tell it's not working, but you're looking for fibrillations that are hard to find. You're looking for neuropathic recruitment that's hard to find. And you can simply, you know, with ultrasound, you can look at muscle architecture and identify it. Now, actually, we're using the two in combination. You could use an ultrasound guided approach to the long thoracic if you really feel you need that. But I don't think it adds a whole lot when you see it's atrophied and you have the clinical context.
Yeah,
so,
great. I want to ask a question. I said a lot, I think 3 or 4 cases of infants that refer for me for facial examination electrodiagnostic. And the problem only for when this child cries, there is some angular deficits, which is, as you know, a congenital absence of the depressor labii muscles. And some does not know this cases, or rarely to say, when we apply the ultrasound, we can judge if the absence of these muscles.
Certainly, and it's a perfect example of use it. If you're familiar with the muscular anatomy, then you can you know, really identify it and follow it, see if it's there. And you can also, you know, the same thing is sometimes, mostly, especially with an infant or a child, it's hard to get, you know, great cooperation with needle EMG in that circumstance. And sometimes you can see muscle contraction, you know, without the pain involved, and without, you know, and if they're fussing around, you can move and wait till you can get a good position. So I think ultrasound's very, very helpful in that circumstance.
Excellent. I think I must thank you again, the Professor Jeffrey, for this amazing lecture and your time. Thank you very, very much for this talk. And I hope to join us in the future again. I know your time. I know your research time also. Thank you. And
Well, an honor to be with you guys. I enjoyed it. So thank you very much.
thank you. Okay, bye-bye.
Have a great day.
Okay, bye-bye. Thank you.